Hello people, in this video we are going to discuss about neoplasia, its introduction, its nomenclature, and after that the characteristics of benign and malignant neoplasms just until the epidemiology of cancer. Before that we are going to discuss all of this. Okay, let's start with the introduction. Cancer is the leading cause of death in the United States. Only cardiovascular diseases exact a higher toll. Even more agonizing than the mortality rate is the emotional and physical suffering inflicted by cancers. Patients and the public often ask, when will there be a cure for the scourge? The answer to this simple question is difficult because cancer is not one disease but many disorders with widely different natural histories and responses to treatments. What they are trying to say is that cardiovascular diseases cause more deaths than cancers in the United States, and there isn't really any cure for this cancer because it is not just one disease. It is a disorder with widely different natural histories. So like some cancers such as Hodgkin's lymphoma are curable, whereas others such as pancreatic adenocarcinoma are virtually always fatal. The only hope for controlling cancer lies in learning more about its cause and pathogenesis. Fortunately, great strides have been made in understanding its molecular basis, and some good news has emerged. Cancer mortality for both men and women in the United States has decreased during the last decade of the 20th century and has continued its downward course in the 21st century. In this chapter, we describe the vocabulary of tumor biology and pathology and then review the morphologic characteristics that define neoplasia and allow benign and malignant tumors to be identified and distinguished. So that is what this chapter is going to deal about. It is the tumor biology, the pathology, what is neoplasia, and the types of neoplasia. The two most important ones are benign and malignant, right? Also reviewed is the epidemiology of cancer, which produces, so we'll also read about the epidemiology, which isn't really that much important considering your USMLE point of view, and insights that have led to the effective prevention campaigns against certain cancers. Building on this foundation, we then discuss the biologic properties of tumors and the molecular basis of carcinogenesis, emphasizing the critical role of genetic alterations that play in the development of neoplasia. See, genetic alterations play a very important role in neoplasia, but to our surprise, the acquired neoplasms are more common than genetic ones. Finally, we turn to cancer diagnosis, focusing on technologies that are helping to direct the use of cancer drugs that are targeted at particular molecular lesions. Throughout, we give examples of new analytic methods and therapies that are not only changing our approach to cancer treatment but also providing new insights into cancer pathophysiology. Okay, now let's start with the nomenclature. Like before this, all we read was introduction. We are going to study about new analytic techniques and the different kinds of cancer and all. Now let's start with nomenclature. Neoplasia means new growth, and new growth is called a neoplasm. Okay, so neoplasia means new growth, right? Tumor originally applied to the spreading caused by inflammation, but the non-neoplastic use of tumor has almost vanished. Thus, the term now equaled with neoplasm. Okay, initially we used the term tumor. Tumor was just associated with swelling caused by inflammation, but the non-neoplastic usage of tumor has almost vanished. Thus, the new term is equated with neoplasms. Oncology is the study of tumors or neoplasms. Although all physicians know what they mean when they use the term neoplasm, it has been surprisingly difficult to develop an accurate definition. In the pre-molecular era, the eminent British oncologist Willis came closest. A neoplasm is an abnormal mass of tissue, the growth of which exceeds and is uncoordinated with that of normal tissues and persists in the same excessive manner after cessation of the stimuli which evoke the change. So British oncologist Mr. Willis, what he told us is that a neoplasm is an abnormal mass of tissue, the growth of which exceeds its uncoordinated with that of normal tissues and persists in the same excessive manner after cessation of the stimuli which evoke the change. Okay, so evoke the change in the sense he is trying to mean the mutation, and it persists in the same excessive manner in the sense it is multiplying rapidly even after the mutation has already occurred and there isn't any further mutations. In the modern era, a neoplasm can be defined as disorder of cell growth that is triggered by a series of acquired mutations affecting single cell and its clonal progeny. Something that we need to understand about neoplasm is that it is not just one single genetic mutation, alright? It is a combination of mutations. First, we'll have an initiator mutation, and then there's something that we call driver mutations that will add on to this initiator mutation to cause the cell to get into malignancy, okay? As discussed later, the causative mutations give the neoplastic cells a survival and growth advantage, resulting in excessive proliferation that is independent of physiologic growth signs. All tumors have two basic components. Okay, before this, what we read is that these neoplastic cells, they will get a survival and growth advantage because of the mutations that they go through, and this will result in excessive proliferation and independent physiologic growth signals. They don't need growth signals from other cells, like growth signals from extracellular entities, to grow and proliferate. They create their own growth signals. All tumors have two basic components. First is neoplastic cells that constitute tumor parenchyma, and second is the reactive stroma made up of the connective tissue. What happens is that, let's say this is a cell and it has undergone neoplasia, and it will produce more cells around it, right? It will produce more and more cells, and in between these cells we will have our stroma that is made up of connective tissue. This stroma, it is made up of connective tissue and it lies in between these cells, and this is the stroma, this is the stroma, right? This is the stroma, right? This stroma causes it to be, adds more fibers to the neoplasm, made up of connective tissue, blood vessels, and variable number of cells of the adaptive and innate immune system. This stroma, it is made up of variable number of cells and adaptive immune system, connective tissue, blood vessels, okay? The classification of tumor and their biological behavior are based primarily on the parenchymal component, but their growth and spread are critically dependent on their stroma. See, we classify tumors based on their parenchymal component. Parenchymal in the sense, these components, these cells that make up, we classify them into benign and malignant based on the genetic composition of these cells. But their growth and spread are critically dependent on the stroma also, right? Are critically dependent on stroma. In some tumors, connective tissue is scant, and so the neoplasm is soft and fleshy. In other cases, parenchymal cells stimulate the formation of abundant collagenous stroma, referred to as desmoplasia. Some desmoplastic tumors, for example, some cancers of the female breast, are stony, hard, and serous. See, as I said earlier, cancers can be divided into two different types. First is your benign and second is your malignant. Benign in the sense it is localized at one particular state and it is not very progressive when compared to malignant. The stroma is the stroma is scant in benign, and the stroma proliferates very much in malignant cases. So the stroma is very thick and very hard, like you can feel the tumor to be very hard in case of malignant tumors, and in case of benign tumors it is very soft and fleshy, okay? Let's start about benign tumors. A benign tumor is said to be benign when its gross and microscopic appearances are considered relatively innocent, implying that it will remain localized and it will not spread to other sites, and it is amenable to local surgical removal. Understandably, the patient generally survives. However, benign tumors may cause significant morbidity and are sometimes even fatal. In general, benign tumors are designated by attaching the suffix oma. Like we attach a suffix oma for benign tumors, but something that we need to understand is that we do have few exceptions. Every rule has some exception, right? So benign tumors, we attach the suffix oma, but there are some exceptions which we'll deal with later. To the name, we'll attach the suffix oma to the name of the cell type from which it originates. Tumor of the mesenchymal cells generally follow this rule. For example, benign tumor arising in fibrous tissue is called fibroma. So if you have a benign tumor in fibrous tissue, it is fibroma. A benign cartilaginous tumor is called a chondroma. In contrast, the nomenclature of benign epithelial tumors is more complex. Some are classified based on their cells of origin, others on microscopic pattern, and still others on macroscopic architecture. See, in tumors of the mesenchymal cells, it is really easy because they follow this rule that if fibrous tissue is getting attacked, we call it fibroma. If cartilages are getting attacked, we call it chondroma. But in case of epithelial tumors, not mesenchymal, epithelial tumors, it is more complex, because for some we name them on the basis of the cells of origin, and some we name them on the basis of the microscopic pattern, and others we name on the basis of macroscopic architecture. So benign tumors are said to be benign when they will not spread to other sites, and they are amenable to local surgical removal, and the patient usually survives. Okay, and then adenoma is applied to a benign epithelial neoplasm derived from glands. So adenoma is for glands. Although they may or may not form glandular structures, on this basis benign epithelial neoplasms that arise from renal tubular cells growing in the form of numerous tightly clustered small glands is called an adenoma. It is heterogeneous mass of adrenal cortical cells growing as a solid sheath. Benign epithelial neoplasms producing microscopically and macroscopically visible finger-like or warty projections from epithelial surfaces are called as papillomas. See, there are two different things. Papilloma and your polyps are two different things. Okay, just a minute. See, first we have papilloma versus polyps. Something that you need to understand is that papilloma are almost always produced in your epithelial tissues. Papilloma is always epithelial, and your polyps are always present in your inner organs. Okay, so finger-like or warty projections from epithelial surfaces are referred to as papillomas, and those from large cystic masses such as in the ovary are called cystadenomas. Okay, in the ovaries we call them cystadenomas. Some tumors produce papillary patterns that protrude into cystic spaces, and it is called papillary cystadenoma. We have papillomas, we have cystadenomas, and cystadenomas that have papillary patterns are called papillary cystadenoma. When a neoplasm, benign or malignant, produces a macroscopically visible projection above a mucal surface, and for example into gastric or colonic lumen, it is termed as a polyp. So what did we see? Papillomas are those projections that are found in the epithelial surfaces, and polyps are those that are found in your inner organs. If the polyp has glandular tissue, it is called an adenomatous polyp. See, as we saw earlier, adenoma is for glands. Adenoma is for cancer that happens in glands, and if the polyp has glands, it is obviously called as adenomatous polyp. Let's talk about malignant tumors now. Malignant tumors are collectively referred to as cancers, derived from the Latin word for crab, which tend to adhere to any part that they seize in an obstinate manner. Malignant tumors can invade and destroy adjacent structures and not spread to distant sites and cause death. Okay. Not all cancers pursue so deadly a course. Some are discovered early enough to be excised surgically or are treated successfully with chemotherapy or radiation, but the designation of malignant always raises a red flag. The nomenclature of malignant tumor essentially follows the same schema used for benign neoplasms with certain additions. Malignant tumors arising in solid mesenchymal cells are usually called as sarcomas. So the malignant tumors that arise in solid mesenchymal cells are usually called as sarcomas. SARS means fleshy. For example, fibrosarcoma, chondrosarcoma, leiomyosarcoma, and rhabdomyosarcoma. Fibrosarcoma means malignant tumors that is found in your fibrous tissue. Chondrosarcoma means those in your cartilages. Leiomyosarcoma and rhabdomyosarcoma fall under muscular malignancies. Okay, your leiomyosarcoma means smooth muscles, and rhabdomyosarcoma means your skeletal muscles, whereas those arising from blood forming cells are designated as leukemias or lymphomas. Leukemias are reserved for your white blood cells, And lymphomas are tumors of lymphocytes or their precursors. They can be of both B cell, T cell, and all the lymphocytes that we know. Malignant neoplasms of epithelial cell origin derived from any of the three germ layers are called carcinomas. What is the difference between a sarcoma and a carcinoma? If you ask, if it is derived from a solid mesenchymal tissue like your fibroblast, your chondroblast, your smooth muscles and your skeletal muscles, mesenchymal tissues, we call it a sarcoma. And if it is derived from the epithelial, if it is of epithelial cell origin, we call it as carcinomas. Thus, cancers arising in the ectodermally derived epidermis, the mesodermally derived renal tubules, and endodermally derived lining of the gastrointestinal tract are all termed as carcinomas. Alright. Carcinomas may be further qualified. Squamous cell carcinoma denotes a cancer in which tumor cells resemble stratified squamous epithelium, and adenocarcinoma, like as we know, like if stratified squamous epithelium is involved, we call it as squamous cell carcinoma. And if your adenocarcinomas are the ones where your glands are involved, right? Glandular pattern. Sometimes the tissue or organ of origin can be identified and is added as a descriptor, as in renal cell adenocarcinoma or bronchogenic adenocarcinoma, bronchogenic squamous cell carcinoma.